Good morning, everybody. My name is Pratik Patel. I lead our product management team at Paragonix. Thanks for attending this symposium, Beyond Limits, Harnessing Advanced Preservation to Enhance Donor Lung Transplantation. We have a phenomenal list of speakers. Before they get started, I want to introduce the CEO and founder of Paragonix Technology, Dr. Lisa Anderson.
Hello and welcome to our industry symposium, Beyond Limits, Harnessing Advanced Preservation to Enhance Donor Lung Placement. Before we begin, I'd like to take a moment and thank you all for joining us today. By being in this room and joining our incredible panel of speakers, you are all witness to increasing evidence for positive clinical outcomes using advanced lung preservation with Paragonix. And you are witness to a changing standard of care in lung preservation. The Guardian Lung Registry has now reached close to 400 enrolled patients across 6 transplant centers, and the results of the registry have been truly inspiring. Our investigators are sharing continued robust evidence of the positive impact of LUNGguard using data from our Guardian registry. The past year has shown tremendous growth for our clinical community. We've also seen transplant centers increasing needs for outsourcing various aspects of the organ procurement, coordination, and transport processes. As a medical device company, we feel it is our job to not only provide our community with best-in-class technology, but also to assist in the access to organs for our transplant partners. It is our great honor to walk shoulder to shoulder with you as you seek to provide life-saving transplants for your patients. At Paragonix, we have thus heavily invested in our personnel and digital technologies in order to provide services support for our transplant partners. To date, Paragonix devices have been utilized in over 3,000 thoracic transplant procedures. Paragonix has provided clinical support in over 600 thoracic procurements. In the past 12 months, we have utilized our 35 product hubs across the country and have provided close to 400 devices on demand, often within just a couple of hours of a request. In close collaboration with our incredible surgical services partners, we have assisted many thoracic surgical procurements across the United States. We are 100% committed to research related to improving patient outcomes, and I am excited to announce that our Guardian registry has now been expanded by Guardian Procure. Guardian Procure is dedicated to the collection and analysis of data generated from outsourced organ procurements and will thus provide important insights into the increasing need for centers to outsource organ procurements with on-demand surgical and preservation teams across the nation. In line with our relentless pursuit for data-driven and technology-enabled practice changes, I'm honored to introduce our expert panelists for today's symposium. Please welcome Dr. Jasleen Kukreja from UCSF, Dr. Howard Huang from Houston Methodist, and Dr. Matt Hartwig from Duke. Thank you.
So our first speaker is going to be Dr. Jasleen Kukreja. She's a cardiothoracic surgeon and the director of lung transplantation at UCSF.
Good afternoon, everyone. How's everybody feeling? You know, lunch should not be provided at these meetings. They're going to have postprandial state, so at least I'm going first, so it's okay. All right. Okay, so I've been using LUNGguard for now nearly 2 years, and I'm not paid from Paragonix. But I'm just going to come out and say this has been one of the most fabulous teams that I've worked with up until now in all the device-related things that I've used. So thank you so much. Okay, so when we're talking about allograft preservation, and I think that's true for probably all the organs, but today we'll just focus on lungs, there are several opportunities for things to go wrong. But for today's purposes, we're just going to focus on organ preservation. And even during organ preservation, a lot of things can go wrong. So how do you maintain viability and functionality of the organs? One of the factors that has been implicated in this arena is the temperature that we store the organs in. And what Paragonix did was come up with this donor lung preservation system, which very nicely, uniformly maintains the temperature constantly at a set level. So, as I mentioned, the LUNGguard became available to us in July. It was, I think, approved the same year in the US, and we started using LUNGguard in July of 2021. And after the first, I would say, maybe 3 months or so, we pretty much exclusively shifted to LUNGguard for all our cases. And I think we've done way more than 100 cases at this point. So this is a slide showing the thermal imaging of lungs. These are clinical lungs from a case. On the left is lungs stored on ice, and on the right are lungs stored in LUNGguard. So when you look at so these are thermal images. On the left on ice, the ice is supposed to be 0 degree on the surface, but when you see the temperature, it's below 0. And when those lungs right next to it on the right side, the blue, green, yellow lungs, they were stored on ice for a couple of hours. And when you see them in these thermal images, you see how heterogeneous distribution of the temperature is in those lungs. Either they're very cold or they're very warm. Now, if somebody just came out of this pro-con debate, I guess 10 is not so bad, but these lungs don't look so hot. Whereas on the right side, these are clinical lungs that were stored on the LUNGguard device for almost 12 hours, and they, as you can see, very uniform distribution and very static temperature set at anywhere between 5 to 6 degrees. So, as I mentioned, we started using it. I'm going to describe a case that we recently, well, not that recently, but we did. It was a patient, 64-year-old, who was from Hawaii, and we happened to get organs from Hawaii. When we started to set up the logistics, every once in a while, I would say maybe 1 to 3 organs per year we will get from Hawaii. So when we were starting up logistics, we've gotten pretty good at it. If we were to get a chartered flight, it will cost us close to $100,000 for just the flight. So whereas if you take a commercial flight, you can have long ischemia time, flight can get delayed, et cetera. Not to mention you have to coordinate the OR time with the OPO there. But we have smoothed out all those kinks in the system. So we partnered up with Paragonix to go on this organ recovery in Hawaii, and we really nicely choreographed our times here, departure, OR times at the local OPO, et cetera, which is shown in this slide here. So we left early in the morning, arrived around 12 o'clock, 12:30 in Hawaii, and then we set the OR time around 4 o'clock based on how long it was going to take for us to finish the recovery and then take the last flight out of Hawaii. So, and I'm talking about we did take commercial flight. And the picture here essentially shows lungs going through the airport, through the security strip, and the bottom picture is once we had recovered the lungs, we put the organs on first class seat, nothing but the best for our lungs. So this is the same patient, 64-year-old from Hawaii, ended up getting Hawaii lungs. We had a very well coordinated effort between Hawaii OPO, Paragonix, and us. This ischemia time in the end turned out to be not as long as some of our other ischemia times, but longer than our standard. So 9 hours and 30 minutes. Patient was extubated post-op day 2. This is the X-ray on admission to the ICU. We pretty much had PGD 0 throughout. He got transferred out of the unit on post-op day 4, which is our standard protocol for these patients. And by post-op day 12, he was out of the hospital, and he is doing well. So Guardian Registry was developed for lungs to really rigorously study what's happening in LUNGguard and to disseminate that knowledge and improve outcomes. So in this registry, there are, I think, data from 4 years, from 2019 to 2013. And the primary goal we're looking at is the obviously primary endpoint is primary graft dysfunction. And you see, as Lisa mentioned, there are 6 sites involved, and UCSF is one of those sites that's contributing data to this registry. So looking at the, so we have 229 patients at this point that we analyzed, and this is the basic baseline characteristics of the donors and the recipients. Donors is up at the top and recipient with the purple at the bottom. These were pretty well-matched groups between ICE and LUNGguard, with just a couple of exceptions. One was donor PO2 in the LUNGguard was higher, and the DCD was higher as well in that group, which was statistically significant. Otherwise, the groups were very similar. So this is looking at the total ischemia time in Guardian, and these results were compared to the UNOS ischemia time for the year 2022. The blue bars are LUNGguard and gray are UNOS. So as you can see, starting at point on the x-axis, 6 to 7 hours, you see that most of the long ischemic time recoveries are in the LUNGguard group. So when we look at the clinical outcomes, because that's what it all boils down to, does it work? So again, I think if you see on this, it's a busy table, but just very quickly to review. For the most part, there were no differences observed, with the exception of a readmission rate and the creatinine or renal function. But when you start to look more closely, you see that even though LUNGguard did not reach significance, but there was trend towards significance in every category: PGD, readmission, rejection, you name it. So all those points were heading in the right direction. Now, we have not achieved enough numbers to reach statistical significance, so we will keep you posted as more data becomes available. So this is looking at the postoperative data. Again, PGD and renal function, both are lower in the LUNGguard group compared to the ICE group. And 1 year follow-up data looking at readmission rate, which is significant. Well, yes, it is significantly lower in the LUNGguard group. So the bars on the left are looking at individual time points from discharge to 3, 3 to 6, and 6 to 12, and the one to the right is cumulative readmission rates. And then you can see the survival curve on the left, again, not statistically significant, but we will, again, keep adding to the registry and see if we can reach significance there. This is looking at the rejection data, A2 and greater. The grays are, again, ICE preserved lungs, and blues are LUNGguard. Lighter one is A2 and darker one's A3. So for each time point, with the exception of the very first one at discharge, there's a reduced rejection, both A2 and A3 in the LUNGguard group. So as I mentioned, we have not achieved significance yet because there are not enough patients or data points collected. But when you look at the Guardian Heart Registry, you can see that in fact did achieve significance for the rate of PGD, which was reduced by more than 31% in the Heart Registry. So in conclusion, in this multi-center analysis, what we have seen is a trend towards improved outcomes. I cannot say what may eventually be the end, but so far so good. But we have definitely seen in our very early experience reduced readmission rates. And I think what I like about LUNGguard is its simplicity and its reliability and ease of even carrying it on a commercial jetliner. So thank you very much.
We're gonna hold the questions till the end. Our next speaker is Dr. Huang. He's a chief of lung transplantation at Houston Methodist Hospital.
Okay, thank you very much for the opportunity to speak. I was asked to share our experience about time shifting in terms of coordinating logistics for overnight procurement. So, as many of you who've worked in transplant kind of probably feel this way at various points in time, maybe all the time, right? It's that there are a lot of priorities. Many of them are competing priorities, and you have to keep a lot of plates spinning at the same time, right? And so I think all programs face this to some extent, right? So we want to increase our transplant volumes, but we also want better results. There's a trend toward older and higher acuity patients, more complicated patients. And then from a regulatory standpoint, we want to utilize the available organs and minimize wait time and waitlist deaths, and while maintaining good outcomes. And in addition, there's now financial considerations in terms of organ acquisition costs and transportation costs. And then add to that our new lung allocation system. That adds another degree of complexity to this. So, and I think that the challenge here is that there's also a limited workforce, right? So when you put all these things together, something falls off, right? We have to figure out some way to be able to scale this process up, do more transplants, preserve the quality, achieve all these objectives while working within the constraints of the available workforce. We've got to be nice to our teams. So, I'm sure many of you have hospitals and, programs that encourage mindfulness and, self-care and things like that. And this is great for maybe a little while, but it's not going to fix our problem, clearly, right? And so I think what we need is actually not, yoga, but more flexibility in our system, right? Flexibility in our logistics that enable us to achieve our objectives safely, right? Safely is the key. So I'm going to talk a little bit about our experience with time shifting. So we've been using Paragonix for about a year now at our center. We don't use it for every single case. We use it selectively. We use it as a way to kind of allow us to do cases we would otherwise perhaps not have the timing or the capacity to do. It gives us more flexibility in terms of recipients who may be a little more complicated, need some pre-op procedures. So it kind of facilitates our ability to do these procedures. So this is, usually the conventional procurement, right, where the donor OR time and the recipient OR times are pretty tightly linked. So whenever you get that donor, you want to minimize the cold ischemic time, and you want to get that operation done as quickly as possible. And so there's really not a whole lot of flexibility. But the whole concept of time shifting is, can we introduce a little bit of flexibility here so that we, without compromising the quality of the surgery, but also putting our teams in a position to succeed. So this is based on some work that many of you have seen already and some presented at this meeting. These are studies that have been done by Toronto showing that cold static preservation at 10 degrees is potentially superior to traditional ice preservation in lungs. And the clinical data actually was presented at AATS in 2022, and then their paper was actually published in New England Journal today. So what about the timing in terms of when we do these surgeries? This was a paper that was published by the Hopkins group in 2011, and they looked at the UNOS registry looking at the timing of operations. So they compared cardiothoracic, these are heart and lung transplants, and they looked at clinical outcomes. While there was no statistically significant difference between the two groups, there was a trend towards, the trend kind of favored the daytime operations over the nighttime operations. This was a paper that was published several years ago by the Toronto group and also Manchester. And they looked at the incidence of primary graft dysfunction based on when the surgery was performed, and we're looking at reperfusion times. So I would direct your attention to that kind of sinusoidal pattern at the bottom there, right? So there's an increased incidence of primary graft dysfunction. This is an important and very clinically relevant outcome that affects early and late outcomes in lung transplantation. And it seems to be a higher incidence of primary graft dysfunction. They hypothesize that some of this, there's a biological basis to this in terms of the organ's ability to recover from injury, more inflammation at a certain time. So I think that, there's a kind of biological rationale for this kind of circadian pattern. And then the last paper I want to discuss was from 2021, published in Annals of Thoracic Surgery by the WashU group. This was a single center analysis looking at day and nighttime surgeries and the outcomes. And they looked at early and late outcomes, so major postoperative adverse events within the first 30 days. That included primary graft dysfunctions, reoperations, airway complications, and such. But also they looked at 5-year loss-free survival and 5-year overall survival. And in all of these time points, the nighttime procedures were associated with increased risk. So I think when you take all this together, it suggests that there's a rationale for doing these procedures at a certain time of the day. So I'm just going to touch on a couple cases we did where time shifting occurred. So this first case was a man with OB and pulmonary hypertension. There was a concurrent heart transplant going on during that time period. So when you look at when the lungs arrived, normally you would be doing the transplant immediately. I'm going to use the laser pointer here. So you would be doing the transplant right around here, whereas the case actually started a few hours later. So meanwhile, there was a heart transplant that completed around this period of time. So that gave our team a little bit of time to reset, get ready to do the double lung transplant. So he was extubated, post-op day 1, did well. The total ischemic time was 723 minutes. The second case also involved time shifting. And again, was a period of time where the surgery would have occurred much earlier under conventional conditions. So we would be doing the surgery here, whereas we're starting the surgery first case in the morning. In this case, the recipient was significantly sensitized and required pre-op plasma exchange. The case was done on cardiopulmonary bypass. He was extubated on post-op day 3. Total ischemic time was 690 minutes. So today we've done 22 cases of using LUNGguards, in which 16 cases where there's some degree of time shifting that allows to coordinate logistics. Our analysis shows there's really no difference in these early outcomes. We're going to perform an analysis of Paragonix versus conventional procurement cases at our center. And I want to highlight my colleague Mina Batro's poster presentation tomorrow evening. So if you want to see the entire experience, he's got a poster presentation tomorrow. Okay, so now I want to pivot very quickly and just kind of bring some of these human factors into play, right? I think for a long time because of the constraints of the donor and recipient OR times, right, we're not really paying a whole lot of attention to the human factors, right? It's important that we take great care of our patients, but we also need to take good care of our surgical teams. So this is a F1 pit stop, right? So this picture looks like there's a whole lot of chaos going on. But in fact, what's going on is a very orderly and planned procedure. All right, these guys weren't assembled ad hoc the day before. All these mechanics have worked together for a long period of time. Everybody has a role. This is an example of a process that has to happen very quickly, and things have to happen in the right sequence. The average pit stop occurs between 2 and 2.5 seconds. That's the average Formula One pit stop. Right, so we've had cases, if you think about your surgery, sometimes it goes like this, and it's fantastic, right? Everybody plays their role. Everything goes according to plan. What happens if things don't go according to plan? Well, then this is a 12-second pit stop, Notice the guy bringing the tire while everybody's waiting on him. So, things do go like this, right? And we all have had cases where things come up and things get delayed. And, so I think this kind of operational excellence is something that we want to be able to facilitate. And if there's ways to do this with the device, all the better. A couple more points I want to make is that these are human factors that are very well known in multiple professions. Truck drivers, airline pilots, all right, many of you traveled here by plane, right? These are things that are not kind of an afterthought, right? So when people have to make decisions under time pressure, there's less objectivity. They rely on intuition and heuristics, and they tend to not analyze all the solutions and make good decisions, right, under time pressure. Now, when you add fatigue to that, all right, we're doing these emergent cases in the middle of the night, these other factors kind of become, converge, right, and in a bad way. Right? So are we really setting ourselves up for success? So there's really a rationale for thinking about these human performance factors, right, that support doing these procedures in more kind of a planned fashion, maybe almost like a semi-elective fashion. Okay, so I'm going to finish my talk with this last kind of description. So I think many of you are aware of this case where the U.S. Airway flight ended up in the Hudson River. All right, so this is called the Miracle on the Hudson. But this is a perfect example of very compressed time frame where there are extremely high stakes. Decisions have to be made in the right order for everything to happen the right way. So you can see that he took off from LaGuardia, and within a minute, he had a flock of geese that took out both engines. Within 30 seconds, he starts executing a turn, and he's deciding, am I going to go to New Jersey and try to land, or I'm going to turn around and go back to LaGuardia? And then within a very short period of time, he decided those were not viable options. And he ended up landing the plane in the Hudson. So if that flight crew hadn't got any sleep the night before, do you think they make the same decisions? Or would you have the same outcome? So there was 150 people on that flight, plus the crew. There were no fatalities. So it was a really amazing kind of demonstration of decision-making under pressure situations. And I just want to put that in to really kind of stimulate some discussion, because I think we really need to look at this with our limited workforce, constraints, and it's important. And there's rationale that supports potentially a better outcome for the patients as well. So we need to put them in a place to succeed, but we also need to put ourselves in a place to succeed. Thank you.
Thank you, Dr. Huang. Next speaker is Dr. Matthew Hartwig from Duke University.
Great, thank you, and good morning for one more minute. It's good to see everybody here, and it's nice to have a sort of a softer talk, a little less scientific than some of the other things, and opportunity to discuss openly afterwards kind of what we're doing and what folks out there are doing in organ preservation. So I'm going to talk a little bit about and focus a little bit more on what we call long-distance lung procurement, and it's going to be wrapped up in both the sort of clinical evidence behind that, and then also some of the logistical challenges that we're going to be facing that we've faced historically, but probably are going to be seeing even more of as we move towards broader sharing. So, long-distance recovery has been a part of the Duke Lung Transplant program for many years now, and even before changes in the allocation systems that have come over the last 5+ years, we tended to look far and wide to try and take advantage of usable lungs across the country. And for the most part, this has been successful, but looking for ways to optimize that, and LUNGguard being one of those ways that we think does help us get the best outcome for our patients. As we talked about, there are clinical considerations as well as some operational execution and logistics that we'll talk about over the next couple of minutes. In terms of the clinical considerations, I mean, I think it should be fairly well decided that PGD is prevalent and bad. And obviously, the incidence can vary depending on the study, how it's defined, how closely it's looked for, how well it's audited by different centers, but continues to be a significant impact on how quickly our patients can get off the ventilator, get up and get moving, and get out of the hospital and start living again. And so continues to be a challenge across the solid organ transplant spectrum. The accepted time for cold ischemia, I think, has been a moving target. We obviously have come a long ways from when less than 6 hours was sort of mandated or requested in the lung space. But clearly, ischemic time does impact primary graft dysfunction at some point, and really trying to understand where that point is important. I don't think we have that grasp yet, but we are certainly gathering more experience as Jasleen and Howard both talked about in terms of extending out our ischemic times. It's, we can't not acknowledge that we just underwent a major allocation change in the U.S., and that certainly is going to impact all of our programs, and for the better, I think, enhance our ability to increase the lung utilization in the U.S., but it will come at a little bit of a cost of logistics and time, and cost probably amongst the transplant centers, and it's going to require some changes in the way that we go about this practice. So, in terms of LUNGguard, I guess we were the first center here. It says we were, so I believe that. Pratik can correct me if I'm wrong. And this has been, a couple of years in the making. And I think it's interesting, and I think this comment was made in the last session by Jack Haney, and I think, those of us who have used the LUNGguard, I think do it in one of two ways. One is we've made the switch completely, right? So our program has, for all of our hypothermic static storage, our preference is LUNGguard. Now, it's not always available because sometimes we're bringing organs in from other places where the LUNGguard is not present. But if we have a choice, our preference is to bring everything in on the LUNGguard system. And I think the other way people are using it in a more selective fashion is using it for, I think, what they consider some of their higher risk cases, some of their longer cold ischemic times, maybe more marginal donors, or for in the cases where they think the recipients need sort of the smoothest takeoff. And so I think that's one of the reasons why we may continue to struggle to see statistical significance in a lot of the registry data because it's uncontrolled in real world. There's going to be a lot of biases baked into that. But anecdotally, we can say we've been very, very pleased with the Paragonix, and it has become our sort of accepted first choice in cold storage. We're going to, we've seen this a couple of times now, but I think it's important, again, as we enter into continuous distribution, at least in the U.S., I think what we're going to see by natural shifts in organ allocation is longer cold ischemic times, and I think that has historically played some role in why we have been so geographically narrow in our distribution of organs in this country for some period of time, and it's incredibly encouraging to know that on the heels of that continuous distribution, we have probably an improved way to to store organs at cold temperatures that will allow us to safely preserve these organs for longer periods of time. And this can be due to travel. This can also be due to delaying of the ORs and OR logistics and team logistics, as Howard just talked about. So, you know, when we're looking at this from a long ischemic time, you know, unfortunately the numbers are fairly small in the registry, smaller when we focus on really long ischemic times over 8 hours. But I think, you know, you continue to see some of the favorable trends in the Paragonix cohort overall. In the registry, and what I won't present here, but we'll be presenting our single center data at the AATS in just a couple of weeks, and you know what we've actually seen in our own series is for these prolonged times that there's some mitigation of the risk of PGD, and so that story is going to continue in the near future. In terms of the temperatures, you know, and this has been talked a lot about at this conference, it's been incredibly reassuring to track these organs, in this case lungs, but obviously the hearts as well and livers, in these devices, and be able to see very consistent temperatures right at what we think is going to be a good target ideal temperature of around 5 to 6 degrees. And homogeneous in that across the organ. And this is obviously very, very different than what we've experienced and what we've seen when we're putting these organs on ice, as kind of been previously described. In terms of some of the challenges just in operations and logistics, you know, there's a lot of different factors that can challenge our teams as we think about trying to broaden our ability to bring in organs from across the country and truly have a national allocation system and a national utilization system. And so these challenges can include volatility, and that volatility can be volatility in volume in terms of, you know, too many cases and they all seem to happen at the same time. It's never every 8 hours there's a donor offer. Unfortunately, there's 12 at once and then none for 2 weeks. And so being able to leverage resources to try and take care of some of that volatility and variability. The logistical limitations, and I think we've all faced this in terms of who is doing procurements and is that in-house or outsourced. And trying to get teams to the same individual to 3 different hospitals at the same time can be quite challenging. And then finally, looking at organs that may not be perfect on paper, but once you got there, if you had a chance to examine them, recruit them, bronch them, and assess them in person, have a significant chance of being usable. How do we get to a point in our transplant system in the U.S. to really try and get eyes and hands on every lung to make sure that we're not losing any acceptable organs simply because someone's not there to look at it. But we can't, as individual centers, typically afford to do that independently. And so one of the things that we've taken advantage of over the last year or so has been the Paragonix procurement services. And this is sort of white glove delivery service, better than the fridge white glove delivery service that ends up in the front yard most of the time. So, but really from start to finish can help us through having skilled procurement surgeons, supplies and services, obviously taking advantage of the most advanced hypothermic storage system, as well as ground and air travel. And then being able to track the organ, the case, the location, the temperature, et cetera, through a user-friendly app on the phone. And so we've been, like I said, using this over the course of the last 6 months or so, and about 10% of our transplants have actually been procured by the Paragonix team. And we've certainly seen the advantages of that as we have faced challenges with maintaining procurement services by our own team at all times. And what's this done is allowed us to evaluate more marginal lungs at a distance that we wouldn't normally potentially have the opportunity to look at. It can save on flight costs as flights can be arranged but not performed unless the organ is usable and brought back, and set up in a way such that the product and the people are in a hub and spoke across the country. And this is just one example where there was a very usable lung in Alaska, and we couldn't get anyone there, and so the Paragonix team helped put together this logistical map for us, where we got a recovery surgeon from the West Coast to meet up with a heart recovery team that was leaving from Spokane. They got to Anchorage, performed the procurement without any difficulty, and then returned to Spokane with both the heart and the lungs, and then the lung continues on to Durham. Our lungs, I think, were probably flying in coach. They didn't get upgraded, unlike Jasleen's first-class lungs, which I was a little jealous about. But suffice it to say, this required a tremendous amount of organizational skills and logistics. While all of this was happening, I was in bed sleeping and getting ready for the transplant. And so these are the things that I think, that Howard was kind of focusing on, the type of quality both in the clinical care we can provide as well as in the quality of life for our team members to be able to have a service like this manage it. And we ended up with cold ischemic times of a little bit over 14 hours with no significant clinical PGD afterwards. And this would be our expectation each and every time. So just to conclude, I think there's a lot of different reasons why we're going to be seeing longer recovery distances, longer cold ischemic times, and it's refreshing, to know that finally, after a number of years, we've had advances in the way we store lungs that allow us to do that safely and continue to provide the best quality for our patients. And for our program, again, it's been our preferred hypothermic storage unit now for a couple of years. We have several hundred under our belt. Feel very confident in the product and the team, and the procurement services has been really a game changer for us in that regard. So thanks very much for your attention, and looking forward to the conversation.
We're going to open it up to questions while people come up to the mic. Any questions or comments from the panelists? Yep, go ahead.
Hi. I just thought the story about taking the lungs from Hawaii and flying them on public or commercial jet was really interesting. I was wondering if there was any logistical problems with, how do you get that through TSA? Did the people screening them ever freak out and think, hey, we need to open this box and see it? Or did the gate agent say, hey, your carry-on's too big to fit in the plane? What kind of logistics were there with that?
It's a very good question. So we connect with OPOs in Hawaii, and because it's a smaller city, so to speak, and more friendly environment, so going there is not the problem because it's an empty box, right? So it's the coming back is the issue with the organs. So the connections are already made. It's always United Airlines is what we fly. So we connect with the United Airlines crew and the security crew at the airport. Now, having said all that, this particular run, when we were actually going from San Francisco to Hawaii, we got pulled over in the security line, exactly to your point, and they had to call the bomb squad. I should have put those pictures up. So it took about half an hour for them to go through, because there's one, I think it's maybe the battery portion of it, so there's a metal piece which was lighting up. So it took about half an hour, and then they ultimately let us go. And then when we came back from the airport, everything was already set up ahead of time between us and the hospital and the OPO. So the security person from the hospital met us at the airport on the way back and took us all the way to the plane. So
Thanks.
it does require a lot of logistics. I think there may be a person here who does a lot of Hawaii recoveries. I can't see it. I thought Prabhan was here.
Yes, please go ahead.
Yeah, hi. Matt, congratulations for 200 cases. How do you, Yoshi and we were discussing a couple of weeks back at our center, like how do you defend that Toronto groups saying 10 degrees is the best, whereas 4 to 8 degrees for this one? So how do you explain the refrigerator thing that Toronto is doing, bringing the donors and keeping them? How do you explain the scientific merit of those?
Yeah, I mean, I think for me personally, the answer's complicated, right? Because I don't think we have direct comparisons between 6 and 7 degrees versus 10 degrees versus 12 or 15 degrees. So I think we can all pretty confidently say, which is kind of amazing after decades of putting things on ice, all of a sudden within 2 or 3 years, there's a general consensus in the field that putting things on ice is probably not the best way to store these things. But I would say that the absolute ideal temperature has not been, to me, definitively proven. I think one of the most interesting things to me as we were getting into this and starting to use the device in this fashion is just that 4 degrees is not 4 degrees, and so the comparison between 10 degrees and 4 degrees is interesting, but that's not really what we've seen in the published literature. It's really been a comparison of 10 degrees to ice, and so I guess I would say the questions still remain and the science still hasn't been done, but we'll see. Hopefully we'll see soon.
Thank you.
Has this technique changed the indications for donors who go for ex vivo? Like, are you guys switching patients or donors who go for ex vivo instead of this?
I think that's a very interesting concept. Now that we've done several long-distance recoveries with this, I think I probably will consider it instead of ex vivo.
So I think you have to think a little bit about your indications for EVLP, and each center approaches this in different ways. If your concern is around cold ischemic times, then I think an optimal storage temperature is probably going to be, that may impact your decision to use EVLP or not. If you're one of those programs who only uses EVLP, if the lung is not usable for direct transplant, then it's not, going to impact, I think, that practice. So each center's use of EVLP and indications for EVLP is going to probably dictate, how a device like this impacts it.
I think Matt is absolutely correct about that. So my idea, if I were to exchange for EVLP, would be it's a longer distance run and it's maybe an extended criteria donor like we've done from East Coast. We, generally speaking, in those cases end up bringing them on EVLP. But I think I'll think twice next time.
Thank you.
Hi, great discussion. Just two things. One, Matt, I think if you read the papers from 89 and 92. Both papers, they compared lungs preserved at 4 degrees in refrigerators versus 10 degrees. So Joe Cooper and first paper, Hiroshi Date, the second paper. And they did show significant benefits of 10 versus 4. Now, this is old data, 30 years. I think it should perhaps be reevaluated in a more modern era.
Right,
The
so
other thing-
let's focus on, we'll just focus on that for a sec, right? I mean, these are preclinical animal models
Sure.
prior to
Yeah.
the use of modern preservation techniques. So
Yeah.
you're absolutely right, that's what is in those data. But that has not been, I would say, repeated and could be potentially interesting to look at.
The other comment is about Howard's presentation. Really enjoyed about focusing a little bit more on the staff well-being and performance. I think we dismissed that a lot. I can tell you from my own experience, I haven't done a lung transplant at night for over 2 years now. My life completely changed. I can have breakfast with my kids now. I do sports before going to work. I'm much more efficient when I'm doing my cases. I don't spend the whole night doing a transplant and then doing 2 lobectomies, which I don't think it's a good service for the patients as well. And so I think we need to look into that. And the other thing is attracting more people for the profession. We have a severe shortage of lung transplant professionals in North America. And I do think we'll attract more people if we have a more reasonable lifestyle in this setting. So I really enjoyed the presentation. I just wanted to talk a little bit about our experience.
This is going to be anecdote, but I was in the gym with Marcelo yesterday morning, and I can attest from 3 years ago to today, he is much, much faster on the treadmill. So that is the truth.
Yes, please go ahead.
Yeah, well, I'm going to follow up on this one because I do think we have an issue across the cardiothoracic surgical spectrum of we're aging out. I'll be a poster child for that. But the phenomenon of we need to take the toxicity of the work out of it. We tend to pick those individuals for whatever reason, don't get too disgruntled by sleep deprivation. I'm not saying we don't get disgruntled by it, but that we're able to tolerate it. And to make this a more attractive thing for people to pursue, there's a reality here. We don't have enough to do what we need to do. And the whole idea, again, of the procurement teams. Duke and Toronto have been successful, frankly, because they took the toxicity out of doing procurement through a number of different arenas. If we can do that more effectively, and if we can also be working with our OPOs in the hospitals that they have to deal, because so much of this gets into their working to get start times that work for that hospital, which ends up causing all sorts of problems for us on the back end. But this becomes a transplant community response or a solution set, not just an individual center.
Thank you. On the right?
Yeah, hi. Really enjoyed the presentations. Mike Smith here from Phoenix, Arizona. We didn't really talk about costs, and I was wondering if someone could comment on just cost relativity. For example, we sometimes use cost shifting using EBLP, portable EBLP, and I know what the costs are for that. And then the other question I had was, are there any of these components of this device that are reusable rather than all disposable? And if that would be a mechanism to even further diminish the cost on this device?
Yeah, I can start with that. I think there's, the cost analyses are very complicated for a variety of different reasons, particularly in the U.S. I'll say that we, again, in our own series that is going to be presented elsewhere, there's been an interesting change in our sort of direct variable costs. And so that what we've actually seen is a reduction in our respiratory care services costs, mainly through less use of some of the vasodilators and such. And so there may be for programs and each program will have to kind of look into this on their own, but there's probably going to be some downstream cost savings if patients have a more textbook outcome after the operation. And so that's going to be one way to advocate for greater use of something other than ice that maybe costs a little bit more. The other cost thing, which is harder to prove but much easier to accept, is that any service or product that would allow you to use a lung that you wouldn't normally use for a patient. So if that lung is so far away and you don't feel comfortable taking it on standard ice, but you do in a storage unit that provides optimal temperature, that's priceless to be able to get that organ for your patient. And so I think there's a couple of different ways to look at that. But like I say, we've seen some very encouraging results in our own cost analyses that we're going to see some downstream benefit from the use of these products.
Yeah, I agree. Speaking for our centers, I think if this translates into a shorter hospitalization, index hospitalization after transplant, faster extubation, shorter ICU stay, I think there's cost savings that are realized there. I can also say that some of these cases that we did this time shifting in, one of the motivations was that this would otherwise be a case we would have to pass on for logistics. So that's one less case we would do. So in terms of cost savings, I think it fulfills the mission of the program. It gets patients transplanted and allows you to do more transplants.
Yep, on the left.
Hi, Mina Batras, Houston Methodist. Great presentation, everyone. Really enjoyed hearing about everyone's experiences. Hearing just the last couple of points, I think we're all talking about operational efficiency, and what does that entail? It's not just the cost of the product, but also the downstream costs to the center, to the patient, but also providing equity, right? How many more transplants can we do? How many more recipients can we service? To pivot to a question, in your experience, has there been any difference in these clinical outcomes when you use LUNGguard for either single or bilateral lung transplants?
Again, I think I would love to see more controlled setting that these devices are used in, so we could feel better about what we feel like we're seeing anecdotally. My concern is that the uncontrolled registry will never have a p-value because of the way there's so much bias in the selection of the device and the patients. I think also that you're really going to see the benefit on some of the margin. I mean, in terms of, like, if you were thinking about using this and you were thinking about implementing a limited use strategy, starting with those very long ischemic times, starting with not having to operate at night, these sorts of things are the way to kind of introduce it. I don't know how many patients you'd have to enroll if you took a bunch of standard criteria lungs and they were on, in a cooling device for 4 hours. That's probably not going to be where you get your biggest return. But definitely, as you start pushing the donors and the storage times for whatever reason, I think that's where we would definitely see it if we look closely.
Okay, thank you. That wraps it up. But we have a booth in the exhibit hall, so please come by if you have any more questions. Thank you.